Alert Medic 1 respond. Box area 19
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
All right. Welcome back, everybody, to the Alert Medic 1 podcast. It is your host. It's Ken Sanner.
Hey, guys. It's Moose.
David Wittberg.
And our special guest.
Regular guest.
Hey,
how's it? Yeah, it's been pretty regular. It's Brian Spoolhoff.
Welcome back, everybody, for part 3 of our traumatic brain injury series. Yeah, we're going to get into a lot of good stuff today, tie up a few loose ends that we didn't quite get to over the past 2 episodes. And I think we're going to start it off jumping right into it, talking about seizure management in TBI, because that's definitely a major consideration, especially in our more serious TBI. So, I'm going to kick it right over to Brian and just talk about a little bit about the incidence of seizure and why it's so important to manage them aggressively.
Yeah, thank you very much. So seizures this is probably my most interesting, or what I think is the most interesting area with traumatic brain injury. So seizures happen frequently within patients with severe traumatic brain injury, anywhere from 4 to 5%, depending on what the injury is, all the way up to 20-25%, depending on how severe that injury And the way seizures, or we think about seizures in traumatic brain injury, is to actually evaluate early versus late seizures. So early seizures are those seizures that happen within the first 24 hours, in the first 7 days. And then after that, late seizures are anything after 7 days. So our goal for managing these patients is, if they have a high enough risk, which we can talk about in a second, is to prophylactically give them anti-epileptics to try to prevent seizures.
And Brian, seizures aren't just something we might see in the first few days. As you alluded to, they can be after the first 7 days. But this can be a chronic problem for patients with significant TBI as well, correct?
Yeah, so that's something that gets into what we would call post-traumatic epilepsy. And what our goal in trying to treat patients is hopefully prevent some of the early seizures, because early seizures can lead to long-term epilepsy.
I think we should back up and speak to our audience of hopefully a lot of EMS providers and talk about just briefly the importance of stopping seizure activity as quickly as possible in the field. It kind of aligns up with what Brian was saying, is the earlier you stop seizure activity, the less likely you are to see seizure activity downstream. Coupled with that, the traumatically brain injured patient that has even one episode of hypoxemia has about 150% increased mortality rate in the field. So practically speaking, a lot of our patients that are seizing are obstructing their airway, they're becoming hypoxic. So the reason to abort seizures quickly in the field is twofold. One, to stop the seizure and prevent subsequent seizures. And 2, as part of the global treatment for things that could potentially lead to hypoxemia and increased mortality.
And Dr. Wittberg, in addition to that, the incidence of a seizure is going to cause increased intracranial pressure as well, won't it? So
yes.
we're really looking at a multifold issue of why these are such terrible events. And just for both Brian and Dr. Wittberg, if I'm understanding what you're saying correctly, if you have a patient who has TBI and they suffer a seizure and you fail to treat it appropriately, they actually have an increased risk of further seizures, even these post-traumatic seizures. Is that what I'm understanding?
In a very, very broad sense, the longer you take to control seizure activity, the more likely the patient is to continue seizing. Mm-hmm. The longer the patient continues to seize, the more issues they'll have with ICP, with protecting their airway if it's not already secured. So it behooves us in the EMS realm to, go through your primary survey, go through your secondary survey, mitigate immediate life threats, But if you do have a patient with a mechanism and a traumatic brain injury suspected and they're seizing, even if they're just a medical patient having seizure activity, the sooner we can abort the seizure activity, generally the better patients do, which is why a lot of the medications we use can be given IM very rapidly. I'm going to pull up as we continue to talk. There's actually a couple studies that show the benefit of very early seizure stopping. I was going to say early seizure abortion, but that may lead to a couple
Termination.
Yeah, early seizure termination is the way to go.
So, quick question on that: do you consider treating seizures within the primary? Like, you're supposed to mitigate life threats before you do that. Do you consider that or no?
No, I mean, I don't think the National Registry would either. I think if their arm is blown off by an IED, you put a proximal tourniquet on and you tie it tight. Exsanguinating hemorrhage. Then work down your ABCs, and then hopefully you have enough hands on deck for somebody to be drawing up medication to give as you're getting vital signs. And I would not put termination of seizures in the primary survey, but it's something that if you have enough hands, somebody should be working on simultaneously.
Yeah, and just one other thing to consider: somebody who's actively seizing, it's hard to get a accurate mental status and neurologic exam on those patients. So one of the other considerations one of the benefits for us to prophylactically prevent seizures is to actually help us with ongoing neuro exams in the neuro ICU, because if people are fluctuating, that may lead to unnecessary treatment.
That makes sense. Although, kind of play devil's advocate there, I would also argue that if I give somebody 5 milligrams of Versed, I'm probably not going to get a accurate mental status after that either.
Oh, absolutely. So the agents, actually, this is a good segue. The agents that we use to prophylactically prevent seizures there's two common ones that you'll see. So there's phenytoin and levetiracetam. Both of those shouldn't cause altered mental status and allows us to prevent seizures from continuing.
Okay. Brian, how do those work? What's their mechanism?
Excellent question. So we'll start with phenytoin because that's a little bit easier. So phenytoin is a sodium channel blocker. Interestingly enough, phenytoin back in the day was also used as an alternative to lidocaine for an antiarrhythmic because it works actually in the same pathway. But go ahead.
No, and what I was going to say is I think eventually we need to do a neurophysiology series where we dive into everything from basic neuron physiology to how action potentials and stuff work, because people may not have that physiology background. But go ahead. Yeah.
Oh yeah, no worries. So phenytoin as a sodium channel blocker helps actually decrease the rate of action potential, which would decrease it would kind of slow the neurons from firing in the brain, and then that prevents seizures. The alternative would be something like levetiracetam or Keppra. That is also a sodium channel blocker, but it also has some other mechanisms that aren't well understood that we believe affect seizure activity. What you'll find, one of the things that we use to guide which agent to use is the Brain Trauma Foundation guidelines. What that does is it tells us how to manage these patients. And right now, these guidelines that were published a few years ago recommend phenytoin over levetiracetam based on limited data. But that being said, I find that most clinicians, based on some smaller trials, prefer to use levetiracetam mostly because of the safety profile.
Just backing up a sec, if anybody wants to do some side reading, the trial I was referring to before that I couldn't pull out of the top of my head was the Rampart study, and it looked it looked at the it was a randomized control study that compared EMS's arrival to patients that were seizing IM injection of lorazepam or IM injection of midazolam compared to securing an IV and giving IV lorazepam. So basically two benzos. And it was found that if you gave the IM injection quickly, as soon as you arrived, versus taking a little bit longer, which it will, particularly in children that are seizing, and give an IV dose of a benzo, that the group that got an IM injection was much more likely to be not seizing or have cessation of seizures by the time they arrived in the ED. That's one of a few studies that actually just has pointed to the benefit of early benzodiazepine administration in the field for cessation of seizure activity. And just to speak a little bit to our audience, typically phenytoin and I can't pronounce the generic, but Keppra is not something you're going to find in the pre-hospital realm unless you're doing skilled critical care interfacility transport.
So just kind of a cool little synchronicity with that. We actually talked about that on our Facebook page a little bit the other day. And I actually, when I first started working at the agency I work at, we were taking part in the Rampart study, and I actually got to be a part of that. That was kind of a cool thing. Tie it all back together.
Yeah. Brian, could you speak to the kinetics and dynamics of intranasal versus IM injection of benzos?
Oh boy, yeah. So intranasal versus IM.
Yes.
Yeah, I don't know if I could pull literature directly on that. What I can say is that we do use intranasal as an alternative because it has a rapid onset, especially when you are unable to get IV access. But I've not actually looked at the data to compare IM versus intranasal.
Because that seems to be a trend in Maryland, I think, where and my volume is super low. Let me turn that up. So there we go. Where the Maryland protocol seems to be pushing a lot of meds to do IN preferred, and I think Versed's one of those. I know fentanyl is.
It's Versed is one that we can give. I don't know if it's been pushed as preferred, but it's definitely on the
I'll have to
list.
check. I know fentanyl is, but and I've always been. That's one of those things where I just don't understand the mechanism that well of how intranasal can be possibly the same as IM, but that's also I never understood why PO Dex works the same. Has a similar dose to IV Dex, but that's a whole other conversation.
I think we could actually get into that topic, and I could do some research. But the way intranasal works is you have the mucosal. I guess absorption, and then when you actually breathe it in, you can absorb directly from the lungs directly into the bloodstream.
Okay.
But I would have to look. There's some drugs don't work that well intranasal, and I'd have to look into the data behind that.
So there tends to be more pediatric studies on cessation of seizures in the field. 2007 pediatric emergency care kind of mucosal atomization devices were kind of being put out in the field. Midazolam IN was compared to your favorite route, PR administration of benzos. Study of 57 pediatric patients with status epilepticus compared IN mucosal atomized midazolam to rectal diazepam. The intranasal group had, looks like their seizures stopped quicker. They had a shorter pre-hospital seizure duration and were less likely to have a seizure in the ED, undergo ED intubation, receive additional seizure medications for ongoing seizures, be admitted to the hospital, or require admission to an ICU. And then there's a couple other similar studies that followed that supported that. The IN administration of midazolam. But again, this looks like most of the studies I'm seeing were in the pediatric population.
Cool.
Interesting.
I think that's we can probably go segue into causes of, or maybe just go into refractory ICP. What do you think?
Yeah, that's fine.
Unless you guys have anything else.
No,
on,
I'm pretty happy with seizures.
Brian, did you have anything else on?
No, I think we could spend a whole episode just talking about seizure management outside of TBI and the importance for managing seizures in patients who have epilepsy versus alcohol withdrawal. So pearls for EMS, early management of seizures, right?
Don't forget time-sensitive, life-saving interventions. Go through your primary and secondary survey, get a set of vital signs. But if there are additional hands on deck and somebody can be thinking about preparing, drawing up, going through the 5 rights, so you drop the right medication at the right dose for the right patient with the right expiration date, treating the seizure simultaneous to those important things at the top, that would be good.
Good stuff.
Yeah.
So I think as we move into refractory ICP, if people listen to our first episode, that's where we talked about like the mannitol and some other agents on how to treat it. But I think we definitely want to, and Brian definitely wanted to talk about that refractory ICP management. So I think we'll give it back to Brian.
Oh, great. So just a quick refresher with ICPs and why it's so important. As intracranial pressures go up, your brain has a limited space, so the skull has a limited space. So as you have higher pressures, your brain ends up choking itself off from blood supply. You end up potentially having areas of ischemia and worse outcomes. As we talked about, the initial management of ICPs include raising the head of the bed if you can so that you can have blood flow, use gravity to your advantage, using osmotic therapy to help draw out some of that edema from the brain. one of the other things to think about is if all of those have failed, what do you do next? And this is not really well defined within the literature. And this is because, one, there's a rarity, there's a scarcity of the number of cases that have a refractory TBI or ICPs, but also the outcomes are so poor in those patients that trying to find something that improves that outcome, it becomes very difficult. So there's kind of what I would say 2 or 3 key, well, really 4 that we can talk about, but from a pharmacologic standpoint, a couple that are very important. So the first is a craniectomy. Craniectomy is removing a portion of the skull so that you remove some of the barrier, so there's a little bit more room for the brain to grow. And there is actually a study in the New England Journal of Medicine that evaluated this, and they found that early decompressive craniotomy did decrease intracranial pressures, but it didn't improve outcomes. It actually led to worse outcomes, and we can talk to why that is in a little bit, or why they think that is.
And
go ahead.
I was going to say, Dr. Wittberg, you can correct me if I'm wrong here, but in terms of a craniectomy, you could actually do that with a yellow IO needle, correct? And an easy IO drill.
Oh boy, that's a lot of paperwork. I mean, you could do that with like a Black & Decker drill. You could do it with an IO needle. Have you, in all seriousness, have you heard of case reports or providers doing that in the middle of Montana on a trail with like the closest rescue being, I guess, No.
I haven't.
I mean, I've seen like random Facebook photos. I don't even heed.
I think I saw it when my ex-girlfriend was big on Grey's Anatomy. I think I saw something similar there.
Right.
But that's about the closest.
I can tell you, when I trained in medical school in Syracuse, and it might take a while for a neurosurgeon to get in the middle of the night, the ER residents there were trained to do burr holes with a drill to evacuate subdural blood. But that was in the ED, perfect controlled setting, optimal lighting, sterile drill. I don't know that I've personally ever seen a protocol that utilizes an IO or other type of
I don't
drill
even want to
field.
get into that. Like that is,
I'd refer you to your jurisdictional medical director for further guidance on
and
that.
they'll probably look at you like you have 7 minutes.
I was going to say that might be a really good way to lose your certification.
I mean, unless
or your
you're
license.
the only reason I could ever even remotely think that this is acceptable in would be like austere environments or the military when you're stuck on an operation for like months at a time or something and you don't have access to this stuff. But
Right.
yeah, sorry, Brian, we didn't mean to go off on a
We
tangent.
digress.
No, that's okay. I would argue that before people even went down to the consideration of decompressive craniotomy or craniectomy, you'd want to know whether the patient actually had refractory intracranial pressures, and you'd need to be able to measure some of that. Some of it you'd only be able to, if you don't have the devices available to see that, then I would be very hesitant, but I am certainly not a neurosurgeon.
So actually, in all seriousness, I think we need to back up. We were joking a little bit there. So I think it's important for our listeners to understand what a decompressive craniectomy is. Typically, I mean, there's a couple different regions of the skull that can be taken off by a neurosurgeon. A decompressive craniectomy may involve kind of making a midline incision, basically peeling back the scalp, and with a bone saw actually taking off half of the skull. And sometimes the skull is put in preservatives. Sometimes it's, I believe, implanted in a patient's abdomen to preserve it. And the brain is actually exposed and allowed to essentially herniate. And so remember, we've said this many times, the skull is a confined, closed space. There's no room or not a lot of room for swelling. And removing half of the skull allows the brain to swell. You can continue kind of caring for and resuscitating your patient, and over time you hope that the brain kind of contracts. Yeah. There are smaller decompressive craniectomies that we actually do in the community hospital I work in, where we will take off the posterior kind of occipital portion of the skull for people that have cerebellar infarcts or cerebellar bleeds. So I just want our listeners to know that, drilling a hole through the skull with even a large gauge yellow IO needle probably ain't going to do a whole lot for the subset of patients that we're talking about right now with traumatic brain injury. There are devices that neurosurgeons use in the OR routinely to drill burr holes, but burr holes that go into the skull are typically, the diameter is a lot bigger than an IO needle. And they're able to introduce suction catheters and suck out usually subdural or epidural blood around the brain and put in drainage catheters. I'm actually very curious. You made a side comment about the military. I'm actually very curious if we could reach out to any of our military contacts and see if in their operations manuals, their PJs or whatever can jump out of helicopters and do anything like this. But I just wanted our listeners to be clear about what we're talking about when we talk about kind of the drastic measure of doing a decompressive craniectomy.
Yeah, and you bring up some good points, and really the burr holes are used to drain blood and suction out blood versus taking out larger sections of skull, which help allow the brain to expand. Because the last thing you want to do is have a small hole and have the brain herniate out that small hole. So,
if any of our providers have been in the field and seen somebody shot in the head, you've probably seen what Brian just described, because often if there is brain matter related to a gunshot wound, it is kind of herniating out through a little
path
bullet
of least
hole.
resistance,
Exactly.
right? Yeah.
But getting back to, you had mentioned probably one of the first things we should do is determine if our patient has elevated intracranial pressure. And then we should get back to kind of how we work through that. And what I think we need to do is we need to frame this as far as like, what do we do in the hospital, which is important for our providers to know. But then what can we, of those things, what can we do in the field? What's translatable into the field?
Well, we did do the initial management in
Right.
our
Okay.
first episode.
Yeah, you're right.
But I do want to transition to the refractory management because I know you had your notes.
Yeah. Well, what I'll say is the one thing for EMS to be aware of, and I think we brought this up in terms of craniectomy, since this is something that typically happens after the fact, is I certainly have had several patients who've had craniectomies. They don't put the bone flap or the piece of bone back for sometimes a couple years. One of the things to keep in mind as an EMS provider is if a patient doesn't have that and they have a subsequent injury, you may actually, you have to be careful in that region because there's no skull to protect that area. So that might be something just as a consideration. In terms of refractory, there's a couple other things that we can do. There's, from a non-pharmacologic standpoint, also hypothermia. The data on that is still not great, so we don't do it routinely. Hypothermia would be similar to what you would see maybe with a post-cardiac arrest, trying to reduce the body temperature and have some neuroprotection. And then the other two agents from a pharmacologic standpoint that we do is neuromuscular blockers and pentobarbital. Neuromuscular blockers work because what ends up happening is if you can cause the body to completely stop moving, stop having any contractions, it reduces the amount of blood flow that gets sent through the brain. It also decreases the amount of cerebral metabolic oxygen demand by overall reducing any kind of contractions in the body. The other thing is pentobarbital, which probably I think people may have seen a little bit more than neuromuscular blocker. And pentobarbital is similar to any other barbiturate, which are, if you're not familiar with how these work, it's similar to benzodiazepines, but they cause a much more profound suppression of neural function, and you can actually put somebody into a full coma with this. And when I say full coma, you actually can get an EEG, which is similar to an EKG. You'll see the electrical activity into the brain, and you can flatline somebody's brain activity. And that's what we do with pentobarbital, is completely flatline them so that they only have maybe one burst of activity every couple seconds, every 6 seconds or so. And that causes the brain to require almost zero oxygen. And because it requires zero oxygen or much less, then there's less blood being sent to the brain. And because there's less blood being sent to the brain, there's a little bit more space. So that's probably one of the absolute last line agents. Ultimately, you can't perform neuro exams on these patients because they are in a drug-induced coma. They are completely knocked out. And hopefully when as you start to take this medication off, the ICPs have started to resolve and the patient comes out of that. But unfortunately, when we do this, it's usually patients that are towards the end of life.
So what I think is a really good takeaway point for our providers, field providers that are listening, is that everything Brian went through, including the presence of like a PharmD, a clinical pharmacist like Brian, which is important when you go down these pathways and you're putting people into a pentobarbital coma. A lot of these therapies are only done at tertiary care centers, academic university hospitals. And so in the field, I think we have to be careful about referring and transporting our sickest traumatic brain injury patients from inception to a regional trauma center that has very high neurocritical care capabilities. And so hopefully people understand kind of the CDC triage decision tree that we use, I think, across the United States, but also recognize specifically the importance of patients with traumatic brain injury being expeditiously transported to a trauma center with neurosurgeons with neurocritical care capabilities that can run down this algorithm that can get pretty complicated in an effort to give our patients the best outcome. And one thing I will add to what Brian said is that, locally where I work, we're close to the University of Maryland in shock trauma. They do a lot of investigational stuff regarding even higher tier therapies for reduction of intracranial pressure. And there's a lot of foam lectures and other resources on the internet that you can read a little bit more about what I'm going to tell you. But they do decompressive laparotomies. They'll actually open somebody's abdomen to reduce intra-abdominal pressure, which reduces intrathoracic pressure, which improves venous drainage and return from the brain down towards the heart. And they have a pretty large series of patients that have had pretty positive outcomes that have undergone decompressive laparotomies. And again, for our audience that doesn't know what a laparotomy is, it's basically opening up your abdomen from the subxiphoid space down to the pubic symphysis, allowing the skin and the fascia to remain open. And basically the bowels are covered with a vacuum, so like an occlusive dressing attached to a vacuum. And there's some very basic and some more advanced physiologic principles that need to be explained to fully understand how this works. But there's stuff above and beyond pentobarbital which can be done, but again, typically only done at your tertiary care, high-level trauma centers.
And that kind of goes back. This is actually something that Moose and I touched on in a recent pediatric episode we did. I really want us to get together, do an episode, talk about what is definitive care and how important it is for paramedics to understand that, because you definitely have instances, even around the state where, okay, I've got a level 3 trauma center 20, maybe 5 minutes away, and even by air, my level 1, my primary neuro center, maybe 30, 60, 120 minutes. But where is it best to deliver that patient? At what point do we determine, hey, maybe we need to take an extra 20 minutes and go to the level 1 trauma center that has this acute neurocritical care ability,
So I can't speak for all the states in the union. I can speak for where I live and work and breathe medicine and pre-hospital care, Maryland. Maryland is becoming increasingly regionalized and specialized with regard to not every hospital does everything, and very specific hospitals do very specific things. And there's a movement in the EMS community here locally to do exactly what you're talking about. And the most recent iteration of that was taking a patient with a high LAM score and bringing them to a comprehensive stroke center where they have neurosurgery, neurointerventional radiology. They could potentially take somebody with a proximal large vessel occlusion and do a mechanical thrombectomy, versus you're around the block from a community hospital or a lower level hospital that can still treat stroke and as a primary stroke center and can still give TPA, but taking the extra drive, the 10, the 20 minutes to go to a comprehensive center in a patient you think has a large vessel occlusion. So we are already currently moving in that direction in the state of Maryland. We do have a couple of regional trauma centers that we preferentially transport our TBI patients to. And I think what you're going to see over time is smarter EMS protocols being developed that speak to taking patients with specific injury patterns to specific centers of excellence, even if it means an extra 10, 20-minute drive or flight.
Yep.
Okay. Yeah, we were seeing that in Massachusetts as well. Specifically with comprehensive stroke, patients had to be diverted to certain centers because certain centers could provide therapy such as that thrombectomy. So,
I do have a question regarding once we open up someone's skull, we are significantly more concerned about infection. So could you speak a little bit to maybe the antibiotics that these people will be getting and stuff like that?
Oh, this is a very controversial topic, actually. I
like it.
So, right. So, what I will say, generally from the antimicrobial stewardship, which is the process by which we try to minimize or use the best antimicrobials for the right amount of time, versus kind of where neurosurgeons tend to lie. And what I'll say is with putting in EVDs or extraventricular devices, those are the devices that will go right into the brain, maybe into the ventricle of the brain to help reduce, either pull out CSF or reduce some pressure. Typically, all you need is a one-time dose of antibiotic prior to placing that, to prevent maybe a infection from occurring. But what you don't want to do is prolong that, because what we found is that prolonged use of antibiotics for these cases actually increase the risk of multi-drug resistant infections. So for example, what you'll see is maybe cefazolin, which is a cephalosporin being used. It helps kill some of the skin bacteria. That prevents you from getting the infection. But if that gets continued on, then you end up getting more infections that might be more bugs that aren't killed by cefazolin. Sometimes, like for example, MRSA, we might see that more frequently. So the answer there is one-time dose prior to the surgery, maybe 1 or 2 doses post, but nothing more than that.
Good stuff. Thank you.
Yeah.
So I think it's is there, if we don't have anything, I mean, I do want to talk about long-term rehab a little bit, especially the meds that, you know, our clinicians might see for like the chronic patient they're responding to. So maybe let's talk on that, and then let's talk about like what the ultimate end goal is for the TBI patient, like what the definitive care is.
Yeah, we can certainly. Yeah. So I won't be able to speak in terms of the long-term rehab and going to rehab centers, because really that's very specialized care. There's some very smart people in that field who are working to make sure that these patients have as best of a recovery as possible. But to kind of prep patients, there's really one big agent that we use. It's called amantadine. Amantadine, the interesting thing about this drug is it was originally approved as an anti-influenza drug. And very quickly and rapidly, there was resistance to amantadine, and there became really no use for it. And had a lot of adverse effects, some neuropsychiatric effects. Well, it turns out that those neuropsychiatric effects are really beneficial in patients with traumatic brain injury. So there was an article in the New England Journal of Medicine back in 2011 that compared patients getting amantadine versus placebo, starting about 4 to 16 weeks after the original injury. And what they found were patients who were initiated on amantadine had an accelerated rate of recovery. They got to the end, their peak recovery faster than those who did not have amantadine. But once the amantadine was stopped, the groups leveled out, and there was the exact same end goal in terms of recovery. So that's, while we often will do this because it's really the only agent we have, there's still a lot of controversy of what the long-term benefit of amantadine is. There's some other agents that are used that I've seen with very, very limited data based on case reports or theoretical. Modafinil, which is also known as Provigil. This is used in patients who have narcolepsy to keep them awake. Sometimes I will use this in patients who have some recovery but are often falling asleep during the day, are having trouble maintaining consciousness. We've tried that. People have also tried amphetamine salts or methylphenidate, which are usually used for ADHD. And what's really interesting is there's been small case reports of people using Ambien to actually wake people up, because it changes the neurochemistry within the brain, and it causes people to kind of become a little bit more aware when they have traumatic brain injury. That's based off of a very small trial that had a remarkable recovery rate. So it's a little sketchy of whether people truly believe that that's always the case.
Can you speak at all to what kind of behavioral or psychiatric issues TBI patients sometimes face, and are they managed in similar ways to other types of issues?
Yeah, so you end up running into kind of a multitude of issues. Part of it is due to the brain injury itself. Part of it is due to long-term being in the ICU and causing something called ICU delirium. You can have both hypo and hyperactive cases. Hypoactive being patients who are just not moving or maybe not as aware, and that's where we use some of these stimulant agents. And then there's hyperactive, so those are patients who are delirious, similar to what you might see with dementia patients. They may become violent. It's not at all, if you have TBI, this is what happens, but certainly we see those cases and they become difficult to manage. We try our best to use antipsychotics, use benzos if people are acutely agitated and irritated, then they may hurt themselves. But it's a balance, and you kind of treat them the same way as you would other patients with kind of combative behavior or other issues.
Yeah, it's interesting. I think one thing that our listeners should take away from this series is that TBI is not a one-size-fits-all thing. The brain is so complex and in a lot of ways still so poorly understood that it's kind of like, almost anything can happen for any patient. You can see so many different presentations. You manage the symptoms the best you can, and that's kind of what it comes down to. So what is the ultimate goal, the end therapy, the end point? What do we want to see for our TBI patients?
Well, our long-term goal is full recovery, functional recovery. I think one of the debates that we've had in neurocritical care, and we're starting to see this in critical care and other maybe even emergency medicine, is we've realized that there's more to a recovery than just mortality alone, or some of the endpoints that may lead to mortality, decreases in mortality. So as I mentioned earlier, that craniectomy trial in TBI, that found similar rates of mortality. It found a significant decrease in ICP, but no changes in functional outcome, which means patients at the end were just as disabled with or without that endpoint. So is that really the best is that the best intervention if it actually doesn't improve outcomes? And worst case scenario, there's some interventions that decrease mortality, and so that would have normally been considered a positive outcome. But what it did was increase the modified Rankin score, which is a score that determines the ability of functional outcome. And so instead of having more people, or it's because less people died, there were more people who were in a permanent vegetative state.
Yeah.
So that actually that's probably a bad intervention. If, even though we decrease mortality, if they are more likely to be have zero function, then is that really what you want in life?
It kind of reminds me of the current controversy and study going on with epinephrine and cardiac arrest, where we know epinephrine increases survival, but it also increases poor neurologic outcomes.
And
what are we really doing?
Yeah, and this really goes back to some, in my career, some of the people that I used to transport a lot, because of their illness, and some of them were TBI patients, they had no quality of life, right? And I know that goes into a larger ethics thing and all that, which I know gets thought about at a way higher level by people that do this a lot more, but just for the average clinician, right? You get called at 2 a.m. for the same super upset family that's taking care of their 20-some-year-old son who was this, in my experience, in my particular case, this up-and-coming athlete that had a gross, injury and now is bedridden with a peg tube and a cath. And I mean, where do we fall ethically? Not in the EMS. This is not for changing EMS treatment or anything, but as a part of a larger medical community.
Absolutely.
You know what I mean?
And I would even take it to the next level. I had a patient who was, quadriplegic, peg tube, everything, but still mentally aware.
Yeah.
I don't know if I'd almost rather be the guy in the persistent vegetative state, that's just tough to imagine living like that,
Yeah.
Ideally, I'd never be either, but
yeah,
we don't get to pick what life throws at us.
So yeah, I think the key is even though this isn't something that necessarily you would see as an EMS provider taking in these patients, but the interventions as we start to evaluate what's beneficial, those are the things that as an EMS early intervention we should look at. Certainly if it improves mortality, that's great, but what are the outcomes of that?
And also how critical the interventions that we do end up doing may end up affecting the patient 5 years from now.
Yeah.
Just a little nerding out just for a sec. Brian had mentioned the modified ranking score, and this is actually something that I've seen in some progressive EMS protocols. When talking about goals of treatment for TBI. There's a very industry standard way to gauge a person's functional status after stroke, after TBI, and it is the MRS, the Modified Rankin Score. It's scored 0 to 6, and I have it up here on the screen, 0 being no symptoms at all, 6 being dead. And the further you go down the scale, the higher the number, the more assistance you get. People with a modified ranking score of 0 have no symptoms, and 1 and 2 have slight disabilities but can usually perform all activities of daily living. 3 through 5, you need assistance, and 6 is obviously dead. So we typically shoot for outcomes with a modified Rankin of between 0 to 2. The reason I bring this up in an EMS podcast is that it's critically important, both in TBI patients and stroke patients, for our field providers to convey to the receiving hospital staff some gathering of information of what was the patient's baseline functional status. Because a lot of heavy decisions, whether it be the administration of TPA or doing a thrombectomy for an ischemic stroke, the aggressiveness with which we resuscitate a patient with a traumatic brain injury, is born from what the patient's baseline MRS was. So you may start to see this in some of your protocols. It appears in some of the EMS research protocols. If you read any papers on outcomes after brain injury, you're going to hear MRS, Modified Rankin Scale. Thought I would just show that to you guys.
Okay.
Yeah, that's great. And we're what we used to look at as modified Rankin scale as a sole endpoint. We're actually looking at changes for patients who may have already been disabled to begin with, as you mentioned, and if they had an improvement. So if they were a 3 to begin with, if they continue to be a 3, then is that a good outcome or not?
Good stuff. Any last minute pearls or anything? Well, anything you guys want to talk about with TBI? Anything else?
The only thing I wanted to say, and I've been holding this in for like 20 minutes now, when Dr. Wittberg was talking about peeling back the scalp and drilling out the skull, especially with Halloween approaching, the only thing I can think is that scene from Hannibal where he's like scooping out the guy's brain with a spoon, and totally off topic. I was like, I don't want to disrupt the show with this, but since we're coming up on the end.
Perfect.
But yeah, any pearls? Anything?
I recently was reading through a really good medical blog preparing for this talk, and in that blog they talked about the issue of traumatic brain injury and coding, running a code basically on a patient's brain, and I think it's just good to review some of the basics. First tier, when able, is to simply elevate the head of the bed, which we actually don't do a lot in the pre-hospital world for a lot of things, but we're getting there. We're actually now ramping up people's heads to intubate them. Imagine that. Elevating the head of a patient with a traumatic brain injury in the field is often going to be difficult because we're usually going to be immobilizing them. Maintaining euthermia is often very overlooked in the field, and can certainly help with ICP issues. If you do intubate, all of these patients should have continuous waveform capnography, and we should be targeting a goal and title of about 35 to 38. Hyperventilation is detrimental for many, many, many disease states, also detrimental in a person with traumatic brain injury that is not herniating. So we target an end tidal CO2 of 35 to 40. And then controlling pain and sedating a patient. So if you do intubate a patient or have the opportunity to safely provide analgesia, that can also help with ICP. Those are kind of your first tier things that most of which can be done in the field. The next tier are things that are typically done in the emergency room, and we've talked about it over the last 3 or 4 episodes: mannitol, hypertonic saline, and sodium bicarb. And then upper kind of level stuff, which we reviewed with Brian today, is administration of deeper sedating agents, propofol, pentobarbital, and then extreme things like decompressive craniectomy, and as is done locally, things like a decompressive laparotomy. So it's always important to understand where we as EMS providers fit into that spectrum. And I think this is a beautiful example of how we are part of the spectrum of resuscitation for traumatic brain injury. If you think for a minute that your actions and what you do for a patient in the first 30 to 60 minutes in the field doesn't matter, you're in the wrong profession. There is no patient population that benefits from excellent pre-hospital care more than the patient with TBI.
Brian, any pearls for our EMS folk?
No, I think
just for TBI in general.
Hit the nail on the head. That sounds great.
Good stuff.
Okay.
I'm going to keep my mouth shut.
All right. Well, thank you, everybody, for listening to the Alert Medic 1 podcast. Please check out our website, www.alertmedic1.com. It's got a lot of great articles on it. We try to update it as frequently as possible. We've got a ton of content sitting in the hopper right now that'll be out soon. Check us out on Facebook, Alert Medic 1. We have trying to get daily discussions going there. We have some exciting stuff coming up there as well. Twitter, alert_medic1. And then probably the most important thing you can do if you want to support our show, subscribe to us on the podcast app of your choice. Listen to us every time an episode comes out. Leave us a rating, leave us a review. Let us know what you want to hear. We have a lot of really cool topics coming up. We've really had a plethora of good recordings here lately. So I think we're going to be able to deliver a lot of great content to you soon. So please check us out. Let us know what you think, and we will see you next week.
Peace.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.